Just like to point out that these are plasma cells, in case you didn't know. So I'm going to make the argument that sequential therapy is the best sort of induction for transplant-eligible patients. You know, most of these debates are sort of tongue-in-cheek because we spent the whole morning telling you guys that there are perhaps 8 to 10 different kinds of multiple myeloma, and different ones emerge over time. To say one size fits all probably isn't right, but I'll try to convince you that sequential is more right than combination. Oh, there's all my disclosures. So I hope that most of you are convinced that multiple myeloma is now a chronic malignancy, something that requires ongoing treatment for extended disease control. Of course, improved survival is the goal, but we're now more and more convinced that at the current state that myeloma is not curable, at least depending on what part of the country you get treatment in. We are looking for regimen tolerability. We're looking to keep costs down because these patients are now being treated sometimes for a decade or more. And there's also the worry that you're burning bridges by using all of your agents up front at once. As we all know, there's no CHOP for multiple myeloma. So we want to sort of look at whether patients benefit from deeper responses or a longer duration of therapy. So what I'm not debating today is that combination therapy gives a deeper response than sequential. You can see that over time, as more and more effective drugs are added together, the overall response rate gets higher, and the percentage of patients in complete remission, at least the way we define it, also goes up. So what do we know for sure? Therapy has become better. The survival is now approaching a decade and may in fact exceed that as new agents come out. But at the current time, therapy options remain limited. And we all know that more chemotherapy or more intense chemotherapy is more toxic than less chemotherapy. That seems to make sense. And that deeper responses to therapy do not always translate into longer survival. And I hope I'll give you guys some examples of that. So I see the agents that we have in multiple myeloma as a limited arsenal. I picked a 6-shooter because I could only think of 6 drugs that we can use up front. Lenalidomide, bortezomib, steroids, alkylator, carfilzomib, thalidomide. The pomalidomide has not been tested in upfront studies as of yet. So each time you use a therapy, you shoot a bullet out of your gun and remaining with less to fight with. So what's the goal of induction therapy? Well, the number one goal is to quickly reverse the symptoms that a patient may be having, and we want to get disease control, and we know that disease control can lead to extended survival. So the usual way that we think about multiple myeloma is from diagnosis. The patient goes through induction. There's some sort of consolidation, be a transplant or no transplant, followed by maintenance. And then the patient eventually relapses, and we do salvage, and this recycles until there's death. You'll note that the progression-free survival and the overall survival are measured differently. So there are several possible treatment scenarios. The first treatment scenario is that combination therapy adds to the overall survival. And this goes on the presumption that each salvage therapy that you give is just as effective whether you did combination induction or sequential induction. So combination induction, you get a nice response. You can do a transplant or not, maintenance, and then you go through your salvage. Versus sequential, you get less of a response, you relapse quicker because we know progression-free survival tends to be shorter with sequential inductions, but the salvage therapies are just as good, and the overall survival tends to be shorter. So that's scenario 1. Scenario 2 is such that you do get a greater progression-free survival because you have a deeper response with combination therapy, but the salvage therapies that you give are not quite as good. They're not as effective as if you did sequential induction and then introduce new agents later on down the line. So you can see, although the PFS is longer for a combination, the overall survival is the same. So keep those two in mind. So I ask you guys, what do you think fits the myeloma model better? You may have seen this before, that ineffective treatments don't work at all. And then each subsequent therapy, as they get better and better, you get a dip in response and then relapse. And eventually, everybody relapses. And so as we go through neurochemotherapy options and different ways of giving chemotherapy, we are working towards preventing a relapse. And if we prevent a relapse for as long as the patient remains alive, that's essentially a functional cure. So the natural history of myeloma, you've all seen this slide as well, is that every time we treat a patient, the remissions get shorter and shorter and the responses get worse and worse until the patient becomes refractory. So we have to pick each line of therapy very carefully because it can't go on forever. So we know from the Total Therapy 2 trial that CRs are not always associated with longer survivals. So while it's true that Bartologhi mentioned before that sustained CR at 3 years predicted increased overall survival, achievement of a quick CR and then loss of that response was actually associated with a worse survival. So CR is not everything. So further subset studies show that the benefit of CR may be limited to only a high-risk subgroup, and that patients with a pre-existing history of MGUS or smoldering disease may not benefit from getting to complete remission at all. So to test those two scenarios that I put forth before, I want to take a look at a few trials comparing more chemotherapy versus less chemotherapy that have actual long-term follow-up. Because if we look at these phase 2 trials that reports results after 8 months of follow-up or 12 months of follow-up, we don't really get the whole story if these patients are living for years and years. So in the IFM 2005 trial, this trial compared VAD induction versus bortezomib dexamethasone induction, followed by the option of DCEP consolidation and then a melphalan stem cell transplant. You can see here that the bortezomib-based therapy was superior to the VAD in terms of responses after the first transplant, after the second transplant, and in both the near CR and the VGPR and better rate. So clearly, statistically significantly better to give the bortezomib in terms of response rate. However, when you look out up to almost 5 years, while the progression-free survival is superior for the bortezomib dex, the median overall survival is exactly the same. I'll give you another example. This study by Cavo looked at bortezomib thalidomide dexamethasone versus thalidomide dexamethasone followed by a double autologous stem cell transplant. Patients were randomized to either of the two regimens, underwent collection, then 2 transplants followed by consolidation. So a lot of chemotherapy versus less chemotherapy. And what you see over here is that more chemotherapy indeed does give you a greater overall response rate. This is statistically significant, but you see I highlight this for you. The 3-year overall survival is the same. However, if you look at toxicity, more chemotherapy is more toxic. So what have you done for your patient? You've gotten a nice response, everybody's happy early on, but they wind up with more neuropathy, other adverse events. This propensity to cause early adverse events with more intense chemotherapy is especially important when looking at vulnerable patients, especially the elderly. With the elderly patient, you want to make sure that the initial therapy you give is tolerable so they stay with it and there's a longer duration of therapy, rather than giving something heavy and having them drop out early because of toxicity. So in this study by Heinz Ludwig, looking at thalidomide dexamethasone versus melphalan prednisone in elderly patients newly diagnosed multiple myeloma, these two regimens were compared. And you can see here that the thalidomide arm did have a greater overall response rate, statistically significant. However, because of the increase in toxicity, peripheral neuropathy, the progression-free survival was lower. However, overall survival was getting close to similar. These early dropouts because of toxicity led to all the difference. So we do have to keep toxicity at the forefront of our minds when we're choosing the therapy for our patient. I'll give you another example from the same doctor from Vienna. We're looking at bortezomib thalidomide dexamethasone versus cyclophosphamide bortezomib thalidomide dexamethasone in newly diagnosed multiple myeloma patients. And I've chosen these studies to show you because these studies have years of follow-up. If you're comparing VTD versus CVTD, followed by collection and then transplants, either 1 or 2. Patients not eligible for a transplant did receive 4 more cycles with a lower dose of dexamethasone. Here you can see that these 2 regimens had nearly the same overall response rate, either during induction and post-transplant. The progression-free survival was quite similar as well, and the overall survival at 3 years was exactly the same. However, with the addition of the cyclophosphamide, the grade 3-4 adverse events do go up. So more intense chemotherapy, similar overall survival, more toxicity. There's a retrospective study looking at lenalidomide dexamethasone versus cyclophosphamide, lenalidomide dexamethasone versus CyBorD, and comparing the three regimens retrospectively. And if you look at the CR, near CR rates, it appears that they are quite different and that the cyclophosphamide, lenalidomide dexamethasone arm is less. However, when you look at the overall survival, there's no difference in any of these arms as well. So why would you add on cyclophosphamide when 2 drugs might be sufficient? One more thing, if you look at the peripheral neuropathy rate for CyBorD, you see it's almost 60%. So I was searching around for long-term phase 3 studies for 2 versus 3 drug lenalidomide combinations, and I could not find a one. So I tried to compare phase 2 retrospective data, which of course is not allowed. So I took CyBorD as a sort of a non-IMiD example, and I looked at BIRD, which is my favorite regimen, bortezomib, lenalidomide dexamethasone, or just lenalidomide dexamethasone alone. And you can see that more chemotherapy, again, gives you a deeper response compared to less chemotherapy. However, when it comes down to overall survival, the data is not yet mature. So BIRD I consider to be a 2-drug regimen. VRD, we don't have long-term data. We know it's 97% at 18 months, but we don't know if the curves start diverging or not. So longer follow-up is needed before you can make a definitive statement. So when looking back at the scenarios that I presented before, it appears that combination therapy prolongs progression-free survival, but it does not prolong the overall survival. And that's probably because of either less efficacious salvage or because of early toxicity from multiple chemotherapies given together. So here I kind of summarize my conclusions in that combination therapy gives a deeper response, a quicker response, and a longer progression-free survival. However, sequential therapy is more tolerable. You can give it for a longer period of time. The overall survival is equivalent, and at the end of the day, that's what we really care about. And you have plenty of options that remain for salvage. We have to remind ourselves that myeloma is not a sprint, it's a marathon. You have to play it like a chess game and think about several moves ahead, and you don't want to blow everything all at once. So again, no clear evidence that combination therapy improves overall survival compared to a sequential approach. But there is very clear evidence that combination therapy is more toxic overall. That's it. Thank you.